Hi everyone, I'm Tom Enke. I'm an advanced therapeutic endoscopy fellow at the University of Colorado, and I'm joined today by Dr. Shah, professor of medicine and advanced therapeutic gastroenterologist at the University of Colorado Anschutz Medical Campus. It's our privilege to participate in GIE's author interview series to discuss our article titled Long-Term Follow-Up of Patients Undergoing Cholangiopancreatoscopy-Guided Laser Dissection and Ablation for Refractory Pancreatic and Biliary Strictures. This study was a single-center, retrospective case series assessing the efficacy and safety of 30 patients who underwent cholangiopancreatoscopy-guided laser dissection or ablation for asymptomatic pancreatic or biliary stricture refractory to standard endoscopic interventions. The outcomes of interest were clinical success defined by stricture resolution on cholangiogram or pancreatogram, technical success defined as the ability to successfully perform the cholangiopancreatoscopy-guided laser dissection or ablation, stent-free duration in those who achieved a stent-free trial, and adverse events. Now, Dr. Shah, cholangiopancreatoscopy-guided laser dissection is a novel technique that you've adopted in your clinical practice. I was hoping you could spend some time kind of discussing the technique and indications.
Sure, Tom, thanks, and thanks for that introduction to our study. The patients that we select are often refractory to stenting alone, and in our series of patients, the median number of stent procedures prior to the ERCP with the CPL was about 3. So these are generally currently refractory strictures, and also the technique is utilizing for soft tissue settings both you can use thulium or you can use homium, and we used homium quite a bit in our study because of the fact that we often needed to perform laser lithotripsy over the stones as well as breaking up any fibrotic tissue and strictures. And so the technique usually, and we described it nicely I think in the video, that we protrude the laser fiber just a little bit beyond the stricture, and then it's a gentle from upstream to downstream, so toward the pancreatoscope or cholangioscope, and gentle pressure using watts of anywhere from 5 to 6 to 7 watts soft tissue setting, and then trying to get about 3 quadrants. Sometimes that can be difficult due to the angulation that we are encountering, but our target is primarily about 3 quadrants, and the idea is then to supplement it with balloon dilation. So the true stricturoplasty concept would be a combination of both the laser ablation dissection as well as to follow with balloon dilation to try to expand the stricture optimally.
Okay. And are there specific indications that you look for or reasons why you may choose to perform this technique for patients?
Patients who seem to have, from a pancreatic perspective, the patients that we often utilized in this study were those that had concomitant pancreatic duct stones. And sometimes the stone is impacted right up against the stricture. And when you try to balloon dilate, it's ineffective. The balloon may break. And when we pass the pancreatoscope, we're unable to actually target the stone sufficiently for lithotripsy. And so that's a large aspect of our study and the indications is to allow us to gain access to obstructing stones upstream of the stricture.
Very interesting. Well, our study included about 30 patients with a total of 49 discrete strictures, the majority of which were pancreatic duct strictures, to your point. And over this time period, they underwent 53 treatments with CPL. And then, Dr. Shah, could you review the clinical efficacy of this technique observed in our study?
So the 49 strictures, 41 of them were pancreatic and 8 were biliary. So the large majority of the patients were pancreatic. And the 41 pancreatic strictures, a majority of them were associated with pancreatic duct stones to treat. And the patients had a median, or I should say that the stricture resolution rate in the pancreatic group, if you look at both complete and partial, was about 95%, and the biliary strictures were a little higher than that as far as complete or partial resolution. And we felt that that was a radiographic finding, but more clinically meaningful are the patients that would eventually have stent-free trials. And so at the end of our study, we had about 83% of patients that we were able to get longer term, or about two years of follow-up on, and that were achieving stent-free trial. And in that two-year period of time, half of the patients at 12 months remained without the need for a stent. About 40% of patients, however, at about 12 months required a repeat reintervention. And some may say, well, this is not comparable to surgical type of data, but the benefit, I think, is that many of these patients either don't want surgery or they're not optimal candidates. There were many patients who had multiple strictures, and when you're looking at a surgical intervention in those patients, it would be difficult to offer them just a local resection of the head versus the tail. Sometimes the pancreatic ducts are not dilated enough. In fact, majority of patients, the pancreatic duct may not be dilated enough to consider a lateral pancreatic osteogenestomy or pistola operation. So we found this to be a very good alternative for patients who did not wish to have surgery, or for pancreatic duct stone therapy, it was an optimal treatment to allow us access to the stones.
Interesting. Well, one possible limitation of this technique is the potential need for multiple ERCPs to achieve stricture resolution. In our study, patients who ultimately achieved a stent-free trial underwent a median of 4 ERCPs, including their index CPL session, to achieve a stent-free trial. Perhaps you could address this limitation in our study?
This is a very complex group of patients, and you can see that there are only 30 patients over the course of several years. And so it's patient selection. They're already quite complex. Their pain features are sometimes complex in their responses to endotherapy. We commence endotherapy when we believe that obstructive pancreatic anatomy is leading to their pain. And many times, or sometimes I should say, that we clear the stones, we treat strictures, and their pain remains unchanged. It's frustrating for the patient, for us as well. And so this is a complex group of patients in which multiple procedures are anticipated from the outset, and we try to reduce the need for reintervention with this technique.
Yeah, that's understanding. So fairly complex patient population. And then an important aspect of any novel technique is looking at the safety profile. Would you be able to share your experience with the safety profile and kind of what we reported in our study?
That's an important question to address, because with any newer technologies, as you mentioned, it's important to comment on them and look for them. 20% of our patients had some adverse event. Half of those patients were patients who had abdominal pain flare-up requiring emergency department or hospitalization. 3.5% of them were actual pancreatitis cases. All of these were mild to moderate adverse events.
Okay.
There was one patient that did have a ductal disruption that was laser related, and fortunately we were able to bridge that with a stent. And I would caution any users here that sometimes you can leave a wire when you're early in your experience, to leave a wire beyond the area of the stricture just in case there is some damage that occurs. But overall, the safety profile of this is quite good, and as long as you bridge the defect with a stent, then the outcome should be able to be managed conservatively.
And then any final remarks or any recommendations to any of the viewers interested in potentially adopting this technique in their clinical practice?
Yeah, I'm often asked that question about laser. It's not available in their endoscopy units, and so I would encourage those that are interested to consider collaboration with urology. You can also consider renting or leasing the unit, so that, because the capital purchase would be quite high for most endoscopy units. And so it is accessible. It's almost certain that your urologists are already utilizing the technology, so you could visit with them and they could have a sharing agreement. You could have a sharing agreement with them. There'll be a laser technician that comes. There's hospital credentialing that is required, the laser course, which is predominantly online, to do that. And from then forward, it just becomes a question of appropriate indication and utilization.
Awesome. Well, thank you so much for your time, and thanks for all the listeners out there. Have a good day.
Thank you.